So we're going to talk briefly. I mean, there's going to be a bit of, I hope this thing sort of goes forward or does something. I come from another big hospital in another city, which was opened in the last 3 years. I work at the Fiona Stanley Hospital in Western Australia, and one of the interesting things about this is I was going to talk a lot about how context matters. Our move was completely different. We combined two hospitals. We didn't close the ICUs at the hospitals where they left. Some of the logistics issues were completely different, but many of the underlying issues were fundamentally exactly the same. So I'm currently clinical co-leader of what's called the Futures program, which sounds a bit sexy, but it's not. I'm doing a few other things in Western Australia. This is our hospital. It's a big thing, and it's got a car park. This is an old picture which showed the amendments being made just here. When we built the place, we realised the waiting rooms for the ED were too small because we weren't getting everybody through in 4 hours, and so they had to do a late modification. This helipad is one of our great facility elements. It was built there to do trauma, and then the government decided that trauma wasn't going to Fiona Stanley, so we've got a fantastic helipad that does almost nothing. What I wanted to say to you is I was involved in the process of how you go about opening a brand new facility. And what happened in Western Australia is that we had this report 2.5 years after the hospital being opened from the guys at Birmingham in the UK, and they said, "You're not ready. You will not open." Now, this report got squirreled away into cabinet. It's never been seen publicly, but basically there was a major problem, and what they realised is they'd been building a building and forgotten largely about everything else. And so they put in place Dr. Russell Weiss, and he implemented a program to try and get the place open, and there were 6 key streams in this process: governance, clinical commissioning, and you've heard a great story from Jerry about how you think about clinical commissioning. And I'll talk a bit about department service plans, and they did exactly what happened at the Royal Adelaide. We had a facilities management model where we brought in a private provider. That was completely unique. And ICT was a big part of the story, and because we were moving from 2 hospitals to another hospital, the workforce elements were a massive complication. We had to ask every person, do you want to stay where you are? Do you want to come to the new hospital? We then had to structure every clinical team, and it was an extraordinarily, unnecessarily huge piece of work. In the background, of course, you had to ask the question of, is the building going to be ready? If you know anything about Western Australia, the next building in the sequence in Western Australia was the Perth Children's Hospital, which was delayed by 2.5 years because of lead in the water and asbestos in the building panels, because we gave the construction job to a Chinese company. We got engaged in the process of new service models. We did 130 departmental service plans and flow maps, tried to work out how the damn place worked, because there is no document that tells you how your hospital operates. I would agree completely with Jerry. That work was incredible, yet every one of those documents, you couldn't find them now if you wanted to, but they were critical in developing the approach. One of the big stories is we went for a big new ICT environment. And you heard from Jerry the challenges of opening a new hospital. When you then layer on top of that a massive, ambitious project to be the greatest and latest and greatest ICT environment, it was really challenging. We're the first hospital in Western Australia to have an EMR, and that came on the back of a scanning solution. So we've got BOSNet, which if anybody here is from Barwon, they'll know about. We had to introduce a program to orientate people to a new hospital, 6 new ICT platforms, and the first time EMR. We ended up with over 100,000 hours of staff training, and we had to deal with the problem of other hospitals were reluctant to release the staff even though they were going to become ours in the future. We embedded a privately operated FM provider called Serco. It had experience in running hospital facilities in other countries, mostly the UK, and prisons in WA. But in fact, they were an important part of the team. This was a new issue. And we suddenly overlaid that a new funding model as well. And just to make things really interesting, the government changed the service models that we were going to transfer, and Fiona Stanley doesn't do trauma. After the Birmingham report, they put in place, we recognised we weren't going to open the place big bang, and we actually ended up with a 4-stage implementation. We had practical completion in December 2013 when Multiplex gave us the keys, on time and on budget. We had a plan to open tertiary rehab, which was a really old facility near Royal Perth. We brought in some early medical and surgical in November, started obstetrics from a small secondary hospital near Fremantle in December, and did the big bang, open everything, turned the ED on the 3rd of February 2015. In the ICT space, which I want to try and focus on a bit, we had a massive blue sky ambition to be everything that opens and shuts. And the problem was, we weren't ready. The clinicians wanted everything. We had no ICT scope or framework. and in fact eventually they had to control the whole process and limit it to 43 platforms. We were working in the context of a new enterprise solution, so we're not a standalone hospital. WA made a decision to be an enterprise solution. We have an enterprise service bus, we have data centres, and we're fully integrated with them. And if you've been at this conference and listened to people like Teresa Jacques talking about, you need to know your context. The issues are completely different if you're on an enterprise solution. And my parting email before I came across on Friday was, we are in code yellow across the whole Western Australian ICT network because Fujitsu had done something at one of the data centres and nothing in the health system was working for 2 days. So if you go with an enterprise solution, you have a different set of problems. As a consequence of that, we have massive problems with computer interoperability. We had too much fascination in Western Australia with grow your own, which Western Australia has always done. We had failed development of key platforms to link services together, so this was a bit of a nightmare. Now, if you're into improving health systems, you know from the Institute of Medicine that these are the key issues. Make it safe, make it effective, hit the patient at the middle of it, make it timely and efficient, and make sure there's equity. And these things did sit behind those programs of implementation, and they're really important. Now, those of you will know that health systems don't actually come out really well in the issue of what risk you're taking. Who here bungee jumps? You are taking the same level of risk as being a patient in a hospital. And if you blow everything up by changing the configuration, the IT platforms and the clinical services and the teams all in one initiative, you are asking for trouble. Liam Donaldson pointed out that we don't have good systems to manage true clinical outcomes, and we don't have good systems to manage the impact of what happens when you change a whole system. Now, what is it about this ICT thing that's so engaging? And Hewlett-Packard, who I think have something to do with South Australia, have pretty big ambitions for what you can do with IT. But what we know is that it takes nurses away from the patients if you don't design it properly, but we still know that we're wasting a lot of money in the health system. So when we went for this blue sky solution, we were really looking for evidence of what makes it better. And there are some very good examples of IT completely changing the service delivery. Snow Labs, which is in Norway, which was a partnership with HP, major implementation system supported by HP, and they got these kind of improvements in organisational performance. 30% increase in outpatient capacity, 20% reduction in length of stay, and a 6% overall productivity increase. Any chief executive would go for this. And that is for an investment of around 5%. Now in Western Australia, the ICT investment was running at 1.8% of health budget. That is not going to work in the long term. And if you want to get to a good solution, then it is around the patient, looking at the ideas around the triple aim and getting a quality framework so that the changes you make, the data changes, the clinical improvement is built into the system. I had the privilege of going to Intermountain Healthcare in late 2016, which is a remarkable organisation. They introduced me to the fact that it wasn't until 2012 that you got better performance by seeing a doctor than going to see anybody else. But as they move forward, they recognise that it's about the specialty-led processes of healing and working out how we take that knowledge and build it into our new processes. They've been very focused on moving away from the traditional craft-based medicine model to a profession practice model which is very like team care and is augmented by ICT systems. And they believe this solution produces better patient outcomes, eliminates waste and makes the caring professions in control, but is a great foundation for the use of a shared electronic record. And what it does is it gives you a structure to reduce inappropriate variation with excellent documentation. So their idea is moving away from a quality assurance model of where you fix the broken bit to a modern model where you improve all care by improving the nature of the systems that are in place. And some of these ideas were behind the idea of what we were doing at the Fiona Stanley with an IT platform. I think there are good messages from what we learned at Intermountain. We need to remember that the performance of our clinicians and our ability declines with time, but it's also changing because we have a massive knowledge boom. So we're interested in how we support frontline clinicians to do their job better. And the lessons I took from Intermountain is understand the links, know your data, build approaches which are informed by knowledge, use the frontline data and frontline knowledge to build your systems. Focus on the clinical care, build provider capability and fashion your IT tools to support the provider, not the way the facility operates. We're in a complex environment, complex adaptive system possibly, but we no longer work in a simple model where one doctor provides patient with direct healthcare. If you think the challenge of EMRs is big, think of the challenge for doctors in our system. New guidelines every day, inconsistent knowledge access, unwanted variation and ineffective care leads to falses and errors, and the issue of the performance of individuals in the system is frequently overlooked. Human knowledge is advancing so fast that our systems at the moment don't support the improvement in quality of care. Some of you will know Alan Morris, and he was one of the presenters in Intermountain. I'm going to skip through these slides because I'm running out of time. But he really looked at how you support systems. And those of you who know about computer-assisted management of ventilation will know that Alan was very big on these issues. I'll just click through these because we're out of time. So where do we get to? We're trying to move away from the wall of ignorance, which Teresa talked about yesterday. We know that information systems are increasingly commonly in use, and we need to understand them. We also know that we haven't come a long way in making care better. This is the McGlynn report from 2001, where they looked at the quality of care delivered, and even simple conditions like diabetes were still being poorly managed. We know we can save on mortality. This is US, this is Australia, but we can do better. And if you're going to go about implementing a program, I'll skip through these slides as well, you need to have a structured approach to your project system, because we don't understand what makes the risk of when you do this. And I'll just click through these because we don't have time. So, where do we come to? Human factors are critical. Supporting the human to do better is important. We understand that we need a human factors approach, so when you introduce EMR ICT systems, you must take it into account. There must be feedback loops, and we must understand the impact on the clinician's ability to do the job. If you create a structure around the clinician by your IT systems, then you can potentially improve performance. We understand system risk. This is great work looking at where the Swiss cheese happens, from the latent conditions through the structures and to then avoiding the adverse event. So we know there's huge variation in clinical practice. This is Dartmouth. Differences in intervention rates, hospital services in the US. We know there's a believed opportunity around improving through computing and information science, and I think there's reasonable evidence that it does it. You need this kind of insight into the process. You need to build in the evidence, and you need to understand your care processes, as Jerry pointed out. David Bates and Atul Gawande introduced us to the idea that we have an opportunity to do better. At Intermountain, they've built this into their systems. In their work with Cerner, they're actually putting their models of care and care pathways into their IT platforms. Decision analysis will provide assistance if we can work out how to use it properly. This work shows that you can reduce medication errors by introducing medication order entry. We at Fiona Stanley had a major patient disaster a month after we opened, with a missed result for the TMTP enzyme in a patient who had started on captopril, and we realised we hadn't thought about results notification in going from paper to electronic. I believe that EMRs can provide assistance in improving the quality of care, and Intermountain is demonstrating that. The critical issues in the ICU really came down to the same skill set that was required in opening the hospital. And for us, it was about, we delayed the launch of the ICU SIS, believing we would grotesquely overload the ICU staff in managing the transition and then implementing a new IT system. We had great clinician engagement, lots of training, we had great leadership with a mixed skill set. We had to learn about digiboxes and machine integration. And thank God we had downtime procedures, because on the first day when we moved patients from Fremantle Hospital, the enterprise network fell over and we couldn't even register a patient. This was really important. The delays were inevitable, but I think we've actually managed to achieve, through a very challenging transition, something that looks more exciting than what it used to. And I still believe in this Yiddish proverb that better has no limit. And I thank you for your interest, and sorry for so many slides. I had a job interview at lunchtime when I was planning to cut some of them out.